third, we're in our third of four days for our Aging and Thriving conference. It's been going great. We're so happy to see some new faces and some people who have joined us for all the days. And today we have a great speaker, Dr. Parker. Dr. Parker is a geriatrician, memory disorder specialist, and physician scientist at Duke. Dr. Parker diagnoses and manages cognitive impairment at the Interprofessional Duke Memory Disorders Clinic. Dr. Parker was born and raised in Durham and completed his undergraduate education at UNC Chapel Hill. He obtained his medical degree and completed his internal medicine residency at Eastern Virginia Medical School in Norfolk, Virginia. He completed his fellowship training in geriatric medicine at Duke and a postdoctoral research fellowship through the Duke Center for Aging. His research interests center on understanding how diet and exercise improve brain health and reduce the risk of developing dementia. So today he's going to be speaking about enhancing healthy brain aging, and we are happy to have him here. Thank you, Dr. Parker. And I'm going to make you a co-host so you can share your screen if you need to.
Yeah.
There you go.
All right, wonderful. So happy to be with you all today. Can everyone see my slides?
Yes.
Yes, okay, wonderful. So today I'm going to be talking about promoting healthy brain aging. What we know to help maintain your cognitive function as you get older, and also what things we can do to reduce our risk of developing Alzheimer's disease and dementia. So my goal for you when you leave today after this session is to have an action plan with a personalized strategy for you to help maintain your cognitive function as you get older and stay sharp. And so a lot of times people ask me how I got interested in Alzheimer's disease and dementia and brain aging. And so the picture you see here is the Forest at Duke. It's a continuing care retirement community in Durham, North Carolina. So it is a community that has apartments and cottages for independent living, and then also has assisted living and a long-term care nursing home on the premises as well. And so when I was growing up, my mom worked at the Forest at Duke. And so I spent a lot of summers during middle school walking residents' dogs, watering their plants, volunteering in the nursing home. And that was my first exposure to kind of aging and dementia and Alzheimer's disease. And that made a really strong impression on me. And so that's what inspired me to pursue a career in geriatrics and dementia research. And actually, when I came back to Duke for my fellowship training in geriatrics, I was able to go back to the Forest at Duke and work there for a year as the physician in the nursing home taking care of patients. So it was really nice to come full circle with that experience. So here's an outline of what I want to talk about today. So I'm going to kind of just start with some background information. I think the terminology can be confusing when we talk about Alzheimer's disease and dementia. So I want to make sure we're all on the same page with respect to what those words mean and how we use them and how we make those diagnoses. I want to talk about what constitutes kind of normal age-related changes in memory and thinking, and what are some more worrisome or concerning signs. And then go through some of the modifiable risk factors for dementia. So these are risk factors that we can do something about. Certain risk factors like genes, we don't have any control over, but luckily there are things that we can do that can help our brain work its best and also reduce our risk of developing dementia later in life. And then also want to talk about enhancing cognitive resilience. Sometimes, with genetic risk factors, we can't get rid of the disease. The disease is going to happen, but we can help our brain adapt to it and cope with it better. And so we're going to go through some strategies that you can do for that that are great, even if you're normal and healthy, can also help enhance that cognitive resilience. And then finally, we'll kind of review our Healthy Brain Action Plan. So just a little background on dementia and Alzheimer's disease. So dementia is a huge public health problem. It causes a lot of suffering and expense for both patients who are living with dementia as well as their families and caregivers. I'm sure many of you have family members or friends who have developed Alzheimer's disease or dementia, and it can be a very challenging disease for that person to live with, to cope with, and then of course for their family members who are watching them change over time. Given that our population is aging and the number of older adults is increasing, we do expect that more people will be living with dementia and Alzheimer's disease moving forward, unless we're able to develop some kind of treatment that prevents it. So as of now, about 10% of people over age 65 have some cognitive impairment or dementia, most commonly Alzheimer's disease. And that number increases to probably about 40 to 50% by the time we get to 85, have some degree of cognitive impairment or outright dementia. So it is certainly a condition that has a lot high prevalence in the community. It's recorded as the sixth leading cause of death, but this is probably likely an undercount, because oftentimes when people die from something related to Alzheimer's or dementia, that's not what's listed on the death certificate. It's some other diagnosis. Dementia care is also very expensive. So for someone who has dementia, the cost per person per year is $60,000. And our country spends lots of money on dementia care, total expenditures of $200 billion. And that doesn't count what caregivers and families are spending as well. And there are also significant disparities with Alzheimer's disease and dementia. So more people living with dementia are women, and there are a variety of factors that go into that. And then we also know that African Americans have about twice the risk of developing dementia as white Americans, and Hispanic Americans have about 1.5 times the risk. So significant disparities there that we need to address as well. So I'm often asked in clinic, or I'm told when patients are coming in and talking about their memory changes, oh, this is just normal. This is just part of normal aging. Is this something I should be concerned about? And so it can be challenging at times to figure out what is normal with aging, because certainly our memory and thinking change with age. Even at my age, I'm 40, I can tell differences compared to how my memory and thinking worked 10 or 20 years ago. So it can be challenging sometimes to figure out, when should you be worried? So things we think of that can occur as part of just normal aging, maybe some lapses in judgment, maybe making a bad decision once in a while. I've had patients and colleagues who, fallen victim to some of these financial scams, and they can be very convincing. If that happens once, doesn't mean you have dementia. If that happens over and over again, might be something to worry about. So similarly, missing a monthly bill every now and again happens to everyone. Not a big deal, nothing to be concerned about. Sometimes you may forget what day it is. You think it's Thursday, but it's really Friday, or the date. But as long as you figure it out later, then it's okay. And then occasionally people may have trouble finding the word they're looking for, but then it comes back to them later, or losing things from time to time. So these are changes that can occur with normal aging. Other changes may be that, it's more difficult to hold as much information in your working memory as once. So that can be something that occurs with normal aging. However, there's some areas of memory and thinking that improve with aging. So our crystallized knowledge, so our knowledge of, kind of the world and facts and things like that increases with age as we learn more. Vocabulary also tends to increase with age. So there are some, aspects of our memory and thinking, not to mention things like wisdom and, things like that get better with age. So it's not all negative. Things to worry about. When some of these lapses or changes, go from happening once in a while to happening more frequently, when they become a pattern, that's really a sign that there may be something else going on. And so, if you're noticing that these things are happening to yourself or happening to a loved one, it's definitely worth getting checked out, talking to your primary care physician about it. Or if other people start mentioning things, sometimes people who are experiencing these changes may not necessarily recognize them unless other people point them out. So maybe, you're telling someone a story and they say, oh, you just told me that, yesterday. Or you're asking a question and someone replies, yeah, you just asked me that 10 minutes ago. That can be a sign that there's something more serious going on, and it might be worth getting checked out. So I've thrown around a lot of words: mild cognitive impairment, dementia, Alzheimer's disease. So I think it would be helpful to take a moment just to define what these mean. What do we mean when we're talking about them? So normal cognition, that's kind of our baseline. That's where we start. And it's important to remember whenever we're thinking about, these diagnoses, whether it's mild cognitive impairment or dementia, it's always relative to the baseline. So for there to be something worrisome, it has to be a change from that person's baseline. So, some people just don't have a good memory for names. They, never could recall people's names. If that's how they are and that's how they've been their whole life, that's not something to be concerned about. It's when there's been a change from that person's baseline that we get concerned. Sometimes we see patients in clinic who've noticed changes in their memory and thinking, but when we do our evaluation, we don't pick up any abnormalities on our testing. Family and friends haven't noticed anything different. It's not affecting their work, their ability to do things they care about. So in that case, we call it subjective cognitive impairment or subjective cognitive change. And there is some evidence that this is a risk factor for future cognitive change. So it is something to be worried about. I think it is worth going ahead and getting checked out, even at this stage, because it can be, an early sign of something going on. The next kind of category is mild cognitive impairment. So this means that there are changes in memory and thinking that, the person picks up on, maybe family members and friends pick up on. We pick them up when we do our cognitive assessment. Although, even though these changes are present, they're not significant enough to impact that person's day-to-day life. They can still do all the things they need to do, to be independent, maintain their household, pay their bills, manage medications, all those things, drive safely, work. They may make errors, more errors. They may, take them a bit longer to complete the task, but ultimately they're able to do it all. And so in that situation, we call it mild cognitive impairment. Now, we do worry about mild cognitive impairment because we know that 50% of people diagnosed with mild cognitive impairment will progress to the next stage, which is dementia, within 5 years. So what differentiates dementia from mild cognitive impairment is that the changes in memory and thinking in dementia are to the point where that person needs some extra assistance with some of these day-to-day activities. They may need someone to help, set up auto pay for their bills and kind of check to make sure everything's getting paid. Or they may need someone to help set up their, pill box for the week so that they'll safely take their medications. So when those changes in memory and thinking progress to the point where that person needs some extra help, that's when we say that person has dementia, okay? So mild cognitive impairment and dementia are what we call syndromes or umbrella terms. So they just refer to a group of symptoms that occur together, but they could have a different cause. It's kind of similar to a cold, right? A cold just describes your symptoms. You may have a sore throat, a cough, a runny nose, a headache, but it doesn't tell you what's actually causing those symptoms, right? It could be, the flu. It could be COVID. It could be strep. A variety of different things can cause those cold symptoms. So just like cold is kind of an umbrella term that describes symptoms, but doesn't tell you what's causing them, that's the same as mild cognitive impairment and dementia. So mild cognitive impairment and dementia, they both tell you, there's a problem with memory and thinking. And then depending on how it affects function, it's either mild cognitive impairment or dementia. So if the person's still able to be independent and do everything they need to do, then it's mild cognitive impairment. If they need some help with some of those day-to-day activities, then we say it's dementia. And it can be a fuzzy line. Sometimes it's hard to make that distinction. And it's especially hard in clinic when we've just met the person and we have limited information to go on. That's why we always like to have a family member or loved one or trusted friend come with the patient so they can help provide some context for some of these changes as well. So these terms capture the symptoms and how they impact day-to-day function, but they don't tell us what's going on in the brain that's causing the symptoms. And so there are different diseases that cause mild cognitive impairment and cause dementia. But by far the most common disease that causes mild cognitive impairment that progresses over time and dementia itself is Alzheimer's disease. So Alzheimer's disease is the most common cause of dementia and progressive mild cognitive impairment. And when we think about Alzheimer's disease, it's defined by the presence of two things in the brain. So the first thing is an abnormal buildup of a protein called amyloid beta. And so this protein is just a normal part of the brain. It's important for the function of our neurons, but for reasons that we're still trying to figure out, in some people, this protein starts to build up and accumulate and form what are called plaques. And so there are genetic risk factors for this, namely the ApoE gene, and I'm going to talk about that in a little bit. And eventually, in some people, not everyone who develops amyloid plaques, but in some people, it triggers the changes in another protein called the tau protein. And this protein starts to build up and clump up as well and form what are called tangles. And those tangles are toxic to neurons in the brain. They cause an inflammatory response, and that causes damage to the brain. And the word we use to refer to that is neurodegeneration. So Alzheimer's disease requires the presence of amyloid and the presence of tau, and that's what causes the disease. Sometimes people can have amyloid buildup, but no tau, and those people tend to be cognitively normal. And about 25% of older adults have buildup of amyloid, but don't have evidence of tau or cognitive impairment. Some people have buildup of abnormal tau without amyloid. That happens in less common neurodegenerative disorders, things like corticobasal degeneration, primary supranuclear palsy, which are much less common than Alzheimer's disease. Now, once this neurodegeneration progresses, then people start to develop symptoms, and this whole process takes around 10 to 20 years. So that's why it's never too early to start looking after your brain and thinking about brain health, because by the time people are diagnosed with dementia, let's say, in their 70s, they've been having this process going on in their brain since their 50s, most likely. So there's a lot of time for us to do something about it if we, start paying attention to our brain health early. So we do know that there are risk factors that can contribute to these changes in the brain, to this disease, and also to its, effect on our brain's ability to function. And so things like obesity, high blood pressure, being physically inactive, having untreated diabetes, and alcohol or tobacco use can all seem to affect this process and increase the likelihood that it leads to disease. And we're still trying to figure out exactly how this works and how these risk factors play a role in contributing to disease. And then there are other things that also can maybe accelerate the process or make people more likely to have cognitive impairment if they have disease. And that's things like hearing loss, visual impairment, being cognitively disengaged, which I'm going to talk about a little bit later, social isolation, mood disorders. We think all of these can take a toll on what we call cognitive resilience. And so for our action plan, we're going to talk about things that about addressing these modifiable risk factors. And then we're also going to talk about strategies to build our cognitive resilience. So even if we have some of these changes going on in our brain, because we can't change our genes, so we may have these changes going on in our brain, we can do things that help our brain better adapt to those changes so that we can still function and still be independent. So if you take two people and they have the same amount of Alzheimer's disease in their brain, one of those people can be completely independent, living on their own, able to manage their day-to-day activities. The other person with the same amount of disease in their brain may be really burdened and may need a lot of help with their day-to-day activities. And we think the difference there is related in part to cognitive resilience. And other things that can help cognitive resilience are being highly educated and having worked in an intellectually engaging field. So those things also help keep your brain strong and help it adapt better to changes like that happen with Alzheimer's disease. So one of the things I want to spend some time on today, especially if you're someone who's younger and you're interested in understanding your risk of developing Alzheimer's disease and dementia moving as you get older, is looking at the ApoE genotype. So the ApoE genotype is the strongest genetic risk factor for Alzheimer's disease that develops after age 65. There are people who develop Alzheimer's disease early. And for a small percentage of those people, it is a genetic disease. It runs in the family. But those genes that cause that genetic familial Alzheimer's disease are different than the ones that cause late onset Alzheimer's disease. So the ApoE gene is the biggest genetic risk factor for late onset Alzheimer's disease. And so, if we think about the contribution of genes versus lifestyle and environment, we think that genes contribute about 60 to 80% of the risk of Alzheimer's disease, while modifiable lifestyle factors, environmental factors contribute the remaining 35%. And so, if we break down that genetic contribution even further, the ApoE genotype accounts for about 5 to 7% of that genetic risk, which may not sound like a lot, but for a gene contributing to a disease like this, it's pretty big. But it's important to remember ApoE is a risk gene. If you have the variant that's associated with an increased risk of Alzheimer's disease, it doesn't mean you're definitely going to get it. It just increases your risk. And so there are 3 common variants of the ApoE gene, 2, 3, and 4. So 2 is a very rare variant, and there's a good amount of evidence that if you have 1 or 2 copies of the 2 variant of the ApoE gene, that you may be at a substantially lower risk of developing Alzheimer's disease. Unfortunately, it's pretty rare in the population. Maybe about 13% of people in the US have 1 or 2 copies of the ApoE2 allele. ApoE3 is the most common version. It's considered kind of the neutral variant, doesn't increase or decrease the risk. And about 60% of the US population has ApoE3 genotype. And then ApoE4 is the one we worry about. This is the one that is associated with an increased risk of developing Alzheimer's disease. And if you have 1 copy of the ApoE gene, then it increases your risk about 3 times. If you have 2 copies, it increases your risk about 15 times. So if we think about the lifetime risk for someone to develop Alzheimer's disease is about 15%. If you have 1 copy of the ApoE gene, then that goes up to about 25, 30%. And if you have 2 copies, then it goes up to about 50%. Unfortunately, Medicare doesn't pay for ApoE genotyping, and most insurance companies don't pay for it either. But if you do something like 23andMe, then you can find out what your ApoE genotype is. But just remember, if you do look into this, that it's a risk factor. It's not determinative. So if you have 1 copy of the ApoE4 gene or even 2 copies, it doesn't mean you're definitely going to get Alzheimer's disease. It just means that your risk is somewhat higher. And it's, very common. I have 1 copy of the E4 allele. So it's, very common in the population. The good news is that there is good evidence that if you do engage in healthy lifestyle activities, like, eating a heart-healthy diet, maintaining physical activity, treating all, medical problems, that can reduce some of the risk conferred by that ApoE genotype. And just some other caveats, we do have evidence that it's a bigger risk factor for women, but actually for African Americans, if you just have 1 copy of that E4, it seems like it doesn't increase your risk. So there are some differences based on your sex and your race, ethnicity as well. There is good news. So despite the fact that our population's getting older and we have more people living with Alzheimer's and dementia, the number of people who are diagnosed every year does appear to be decreasing. And we think that's because we're doing a better job of addressing some of these modifiable risk factors that contribute to dementia risk. And so up to about 40% of dementia cases may actually be preventable by addressing some of these modifiable risk factors. And so what are these risk factors and how do they contribute to dementia risk? So I mentioned before that, this concept of cognitive resilience, if we exercise our brain, either with education or with working in an intellectually challenging field, our brain is, I think of it similar to, a bodybuilder's muscle. It's trained, it's big, it's strong. And so our brain's able to withstand, more challenges down the road because we've, exercised it so well across our life. So there's good evidence that, as looking back over the change over generations, as more people have completed education, both primary school, secondary school, and then going on to college and graduate work, seems like that's had a protective effect and reduced the incidence of people developing dementia. And then other things that play a role in midlife. So hearing and vision vision loss, which I'll talk about later as well. Traumatic brain injury, high blood pressure, drinking too much alcohol, or being overweight, obese, confer an increased risk later in life of dementia. And then things that people can do, modify late in life are things like smoking, mood disorders like depression, being socially isolated, physically inactive, air pollution, and diabetes. So there's a lot we can do to actually mitigate our risk of developing dementia and Alzheimer's disease later in life. And so the key, though, if you're worried or you have concerns or you have a strong family history, is to talk to your primary care doctor about things you can be doing. And if you do have any concerns about your memory, asking for a referral to a memory specialist. I get a lot of questions in clinic about medications and their role in increasing the risk of dementia as well as sleep problems. And so I just wanted to take a moment to go over the evidence that we have. And so this is a very, active field. There's a lot of research going on. And so, things change on a regular basis, but this is kind of where we're at right now. So there are medications that are associated with that can worsen cognition, but we don't have clear evidence that they actually increase the risk of getting dementia. So if you take a medicine, if you take like a Benadryl, I have a lot of patients who take Benadryl to help them sleep. I'm sure if you've ever taken Benadryl before, it can make you kind of groggy, can make you kind of slow. So medications that are in that family, like antihistamines or anticholinergics, and these can include things like amitriptyline, like Elavil, or bladder medications like tolterodine, oxybutynin, or ditropan, and then some antidepressants like paroxetine or Paxil. They have these anticholinergic effects, which can have a bad effect on your memory and thinking. There's some weak evidence that they may increase the risk of dementia, but it's pretty weak. So I think right now the jury's out. They definitely can negatively impact your memory and thinking when you take them. But whether or not they increase the risk of dementia, there's no strong evidence that really supports that. And then other medications like Ambien, sedatives, muscle relaxants, pain medications can also affect memory and thinking when you take them, but whether or not they really increase the risk of dementia, it's unknown. And sometimes it's hard to tell because if someone, sometimes people will develop sleep trouble or develop mood changes like anxiety or depression as part of their Alzheimer's disease process. So those symptoms may appear before they even have changes in memory and thinking. And then they may get prescribed one of these medications. So when we're studying this, sometimes it can be hard to tell what came first. Was it, the medication was started and then they developed dementia or Alzheimer's, or they developed some symptom as part of that Alzheimer's disease process and the medication was used to treat that. So it just looks like there's an association there. And we call that reverse causation. There's also, it's, I think, pretty clear that if you have untreated sleep apnea or you have chronic insomnia, that can negatively affect your memory and thinking because you're not getting enough sleep. But there's not really any strong evidence yet that actually increases your risk of developing dementia. There was a study that looked at sleep and its association with dementia and found a very small increase in risk of developing dementia for people who slept less than 6 hours a night. But otherwise, there wasn't really a clear association. Now, there are other things that we have really good evidence for. So things like heart, liver, and kidney disease, untreated high blood pressure, poorly controlled diabetes. There's really good evidence that all of those contribute to an increased risk of dementia. So that's why it's really important to work with your primary care doctor to make sure that they diagnose and treat these things adequately. There's also some evidence that mood problems, depression, anxiety early in life and during midlife may increase your risk of developing dementia later on. So it's important to address those and get those treated either through, treatment with a medication or non-pharmacologic treatment like therapy or other, interventions. And then there's, I think, very compelling and very strong evidence that hearing impairment is a risk factor for dementia, and that if you use hearing aids, that can be protective. And there's similarly evidence for cataracts being associated with dementia, but it's not as strong evidence yet as hearing. And if you think about it, it makes sense, right? Like if your brain's not getting that stimulation from your eyes, from your ears. There's some evidence that those regions of the brain that receive that input actually may start to shrink. But even, beyond that, just if you're having trouble hearing or seeing, your brain is having to work harder to process that information to try to figure out what's going on and put it together. So if we can offload some of that work by boosting your hearing or treating your cataracts, then your brain has more resources to dedicate to other things. So there are a variety of different factors that can contribute. Also, if you have hearing or vision impairment, it's hard to socialize. It's hard to be active and engaged because you can't hear. And so that may also be part of why treating hearing and visual impairment improve memory and thinking. And then there's good evidence that lifestyle factors like, heavy alcohol use, being a smoker, being physically inactive, eating a poor diet, being socially isolated, and being what I call cognitively disengaged are also risk factors as well. Now, I'm not going to talk much about diet because I think you're getting a whole nother lecture dedicated to that. So I'm going to leave that for the other speaker. So one of the biggest things I recommend for my patients is to start an exercise regimen if they want to help keep their brain working well. And there was a really nice study that came out of the UK Biobank. So this is a really large study out of the United Kingdom, has about 500,000 people in the entire cohort. And it's just been a wonderful resource and a lot of really interesting scientific findings that come out of it. And recently they did an analysis that looked at daily step count and dementia risk over the next 7 years. So they measured people's step count using actigraphy measures, so like what you have on your Fitbit, a little bit more of a nicer version of that. And so they found that people who got around 10,000 steps per day had about a 50% lower risk of developing dementia over the next 7 years. So a pretty substantial risk reduction. Now, this was an observational study, so that means we can't necessarily say that decreasing or getting enough steps reduce the risk of dementia. It could also be that people who were at risk for dementia, for one reason or another, just were less physically active and got fewer step counts. That is a possibility, but I think there's a whole body of evidence that beyond this one study that shows that getting regular physical activity is very protective for the brain. So I tend to believe it. And if you only managed to get around 4,000 steps, that was still beneficial. That conferred about a 25% lower risk of developing dementia over the next 7 years. And they also found that, if you got fewer steps, but at a higher intensity, so walking a little bit more briskly, that was also protective. So even if you can't manage to get those 10,000 steps per day, if you can make the steps that you do get a little bit more brisk, then that can be almost like getting more steps. And it's, pretty easy, I think, to work in increasing step count into your daily routine. When you go to the store, park at the back of the parking lot and have a brisk walk to the door. Try to take the stairs instead of taking the elevator and, walk up the stairs briskly. If you just build in those kinds of changes into your day-to-day routine, it's actually much easier to get your step count rather than just trying to do it all at once. And so another great thing or great opportunity to use exercise that will also help your brain is to make it social. So I really love when people, play games like pickleball or tennis, because not only are you getting great physical activity, you're getting a great workout. It can be moderate intensity. You can adapt it for your mobility limitations. But, you also get that social engagement that's protected for your brain as well. So you can kind of kill two birds with one stone there. Exercise has been shown to be as effective as antidepressant medications for depression and anxiety. So if someone has a mood disorder, then exercise can be a great part of the treatment plan for that. And that can also help your brain since you're addressing those mood symptoms as well. Exercise is a great way to improve sleep. So if it does turn out that, impaired sleep contributes to dementia risk, we certainly know that if you, are sleeping poorly, it's going to affect your memory and thinking on a day-to-day basis. Getting regular physical activity is one of the best things you can do to help regulate your sleep. And then finally, exercise is great for other medical risk factors associated with dementia and Alzheimer's disease, like blood pressure and diabetes. So exercise is really a multimodal intervention that has all sorts of health benefits, and all of which are great for your brain. So if there's one thing, my patients can do that can make a difference for their memory and thinking, it's starting a regular exercise program, because it really hits multiple risk factors for cognitive decline and dementia and Alzheimer's disease. And also, I think it's important to remember that just doing things like gardening or doing housework, that also counts as physical activity as well. So, if you can use that as part of your exercise routine, just try to, make sure you're keeping up a good intensity, doing it briskly so you get your heart rate up, you're breathing a little bit more heavy. But that can also be, part of your exercise routine as well. Something that's come out more recent, I think is really fascinating, and is also part of kind of my research as well, is the role that infections play in contributing to Alzheimer's disease risk. So we do know that, Alzheimer's disease and dementia are associated with increased inflammation in the brain. And there's also some evidence that amyloid beta, that protein that's part of the definition of Alzheimer's disease, might actually function as a microbial peptide in the brain. So it's part of our brain's immune system that defends from infection. And so it makes sense that infections that either increase inflammation in the body or increase inflammation in the brain might increase the risk of developing cognitive decline and Alzheimer's disease and dementia down the road. And there is, I think, an emerging body of evidence that suggests that is the case. Particularly with viruses like these common herpes viruses. So like herpes simplex virus, which causes genital warts and cold sores, and then varicella shingles, which causes chickenpox, and then later in life causes shingles. And then there are other members of the herpes virus family like CMV and EBV that most everyone are infected with. And there's some evidence as well that, if you're infected with those viruses, that you have a higher risk of developing Alzheimer's disease down the road. There's also evidence that, other viruses like influenza, COVID, viral pneumonia increase the risk of developing dementia as well. So the good news is, though, that if you get vaccinated, seems like you might be protected to some degree from that increased risk associated with those viruses. So I recommend people get vaccinated for all the recommended vaccinations. Not just to, keep them from getting the flu or getting COVID, it also might actually protect the brain health. And I think with COVID, that might be particularly important, given that one of the common symptoms of COVID, at least in the earlier variants, was the loss of smell. And that loss of smell actually represents direct brain damage. The cells in your nose that, are important for smell, those sensory cells, they connect directly to your brain. So that's, if you can't smell anymore, that's a sign of brain damage, unfortunately. So, I recommend all my patients get vaccinated for all their recommended vaccinations to help protect their brain as well. So another thing is what I call cognitive disengagement. So I see this pretty commonly in patients, and I hate to say it, but I think it's mostly the men. So they retire. They worked all their lives, worked very hard, and then they retire and, spend most of their time watching TV. And so that's probably one of the worst things you can do for your brain. So it's important to maintain those cognitively stimulating, intellectually demanding, and socially engaging activities that people did throughout their lives as they get older as well, because not only is that going to keep them, involved in their community and keep them connected, but it's also going to help protect their brain. And so I recommend that, people continue to be active and engaged in church or a synagogue or whatever, other kind of community activities that they like to participate in, that they continue to, take part in their hobbies, and that they pick up new hobbies, do things like learning a language, learning how to crochet, learning how to knit, learning woodworking. All of these activities, engage your brain, and that can help build that cognitive resilience that can protect your brain from cognitive decline and dementia down the road. And also, if these activities have a social component, that helps with that social isolation as well. So again, you get to kill two birds with one stone. And one of my colleagues just published a paper, Murali Doraiswamy, that compared computerized brain games to a crossword puzzle and looked at its effect on cognitive performance in people who have mild cognitive impairments. So they have changes in memory and thinking, but they're not severe enough to impact their day-to-day function. It's kind of a precursor stage before dementia. And so they followed these people for about a year and a half, and they found that those who did 30 minutes of crossword puzzle per day had a better maintenance of their cognitive performance than people who did the computerized brain training games. And so the crossword that they used was equivalent to the Thursday New York Times crossword puzzle. So, kind of a moderate difficulty, but definitely, probably cheaper than subscribing to one of those brain game programs. But something as simple as that just exercises your brain on a day-to-day basis can help keep your memory and thinking working better. So I get a lot of questions about other things that people have read about or interested in. So things like the Bredesen protocol, which was popularized by a book called The End of Alzheimer's Disease. It was based on a trial with 10 participants, and it's a personalized medicine approach that involves a lot of things I talked about here. So diet modification, exercise, but they also do hormones and supplements. So, it hasn't been well studied. I don't think it's harmful. The centers that offer it, it's very expensive. So I think if someone's interested in it, it's probably not going to hurt them. But, I don't know that it's going to have a great effect above and beyond just implementing some of these things on your own. Prevagen, a huge marketing campaign, very great. The advertising is really good. I want to start taking it after I see those commercials. I'm like, wow. But there's really no evidence that it helps. There was a study that the company did that showed there was an improvement in cognitive performance. Unfortunately, they didn't have a control group. So if you give someone a cognitive test and then, 2 or 3 months later, you give them the same cognitive test, they're going to do better the second time just because of a learning effect. So that's why we have a control group, right? So if we, are going to, if we want to know if that learning effect or that improvement is real, or if it was just due to learning, we have to compare it to a control group. So they didn't do that. So I don't think you can really, say anything from the study they did in terms of a benefit. It's also pretty expensive. It's about $60 a month. For a period of time, there were clinics that were infusing people with plasma that was obtained from young adults, but the FDA thankfully shut that down. There could be a lot of risk associated with that. It's also very expensive. No evidence of benefit. Same with stem cell therapy. No evidence of benefit. Actually, some evidence of harm. Those stem cell infusions can cause tumors and other problems, and it's very expensive. Hyperbaric oxygen. There have been some small studies showing a benefit with hyperbaric oxygen. It seems like the benefits only maintained for as long as people are doing the therapy. But whether or not it has any long-term benefits, that's unclear. Hormone replacement, whether it's for women or for men, it's controversial. There are some studies that show benefit. There are other larger studies that show no benefit or harm. So I think the jury's still out. It's difficult to study because there's a lot of factors at play. When do you start the hormone replacement therapy? What's it started for? How long do you give it? What, kinds of hormone replacement therapy do you do? So it's a challenging thing to study, and I think the jury's still out with that. And then fish oil, kind of the same thing. Some studies suggest that it has a protective effect. Certainly not really any strong evidence that it's harmful. But I think if you're interested in fish oil, it's probably better just to, go ahead and do the Mediterranean diet, which I think the other speaker will probably talk about as well, because fish is the preferred lean protein in the Mediterranean diet. So for our action plan, and I think, this is a good place to start if you're thinking about what you can do to improve your brain health. Definitely want to treat things like high blood pressure. That's probably the one medical problem that's been most strongly associated with an increased risk of developing dementia and Alzheimer's disease, and even just cognitive decline independent of dementia. So definitely want to make sure that your blood pressure is adequately treated. high cholesterol and diabetes as well, and then stay up to date on your vaccinations. The good news is if you exercise, that can be as effective as a medication for high blood pressure sometimes, and also can help with your diabetes, cholesterol. And so minimize alcohol and quit smoking. I know there's been a lot kind of recommendations to say it's okay to have one glass of alcohol or one glass of wine per day. I think the more recent research is kind of disputed that and really provides I think stronger evidence that there's no safe amount of alcohol. Probably a drink a day is not going to cause too much harm, but there's no evidence that's protective or that it reduces your risk for either heart disease or dementia or Alzheimer's. Definitely would recommend to achieve, start an exercise program, and the bare minimum would be one that has 150 minutes of moderate intensity physical activity every week. And so you can break that up however you want. If it's 20 minutes, twice a day, 30 minutes, 5 days a week. And this can be a brisk walk. So when we say moderate intensity, that just means if you're walking fast enough that your heart rate is elevated, you're breathing a little bit more quickly, but you can still comfortably have a conversation. It's nothing crazy. And then also recommend that you limit sedentary time. So how much time you're just sitting. Sitting for several hours on end, watching TV, reading, doing something else. There's good evidence that that's harmful for your health. And even if you do exercise the recommended amount, it doesn't offset the negative effects of that prolonged sitting. So if you're watching TV, make sure to get up every time there's a commercial, fold some clothes, empty the dishwasher, walk around a little bit, just to make sure that you're not having that prolonged sitting time. And then follow a Mediterranean style diet that's been shown to be good for both heart health and brain health. So definitely recommend that. It's also delicious. Get your hearing checked and use hearing aids if recommended. Same for cataracts. Maintain your social and cognitive engagement. Learn a new skill, learn a new language, do the crossword puzzle. Just find activities that you enjoy that keep your brain active and engaged. And ideally, if those activities have a social component, it's even better because that's helping with that social isolation. And then with respect to supplements, there was one well-designed large study that showed a very small benefit with a daily multivitamin, and that was compared to a coffee extract. And so there was just a small benefit in cognitive performance with that daily multivitamin. There are lots of other studies looking at other types of supplements, but they're generally small and they haven't been replicated. So it's really hard to know if it's real or not, or if it was just due to chance. But many of them are not going to be harmful. So if it's something you're interested in trying, I would just talk to your doctor about it and make sure there's no red flags for that particular supplement. So what do you do if you're worried about your memory and thinking? So, I think it's never too early to get checked out. If you or your loved one have concerns about memory, talk to your primary care doctor about it. See if it would be appropriate for you to be seen at a memory clinic. Or you can just call your local memory clinic and request an appointment. So at the Duke Memory Clinic, we do specialized testing to diagnose Alzheimer's disease, Lewy body disease, and other causes of memory and thinking. In the past, when people came in and we did an evaluation and we made a diagnosis, it was just based on their symptoms for the most part. We didn't do any specialized diagnostic testing to prove that their symptoms are due to Alzheimer's disease or Lewy body disease. That's changed. We now have diagnostic tests that we can use to tell us if someone's symptoms are due to Alzheimer's disease. So if you come in and that's what we're worried about, we can actually do a test to figure out if that's what's going on. And why is this important? Well, in the past, we didn't have any treatments that could convincingly slow down changes in memory and thinking due to Alzheimer's disease. In January of this year, that changed. We have the first FDA-approved drug that convincingly slows down changes in memory and thinking due to Alzheimer's disease. It's called lecanemab or Leqembi. So we now have an option to start treating people, who have these changes that are due to Alzheimer's disease. And we're also testing this medication in people who have evidence of Alzheimer's changes in the brain, but are cognitively normal, to see if it can actually prevent the development of cognitive changes due to Alzheimer's disease. So that's another reason why it's never too early to get checked out. because we may, be able to use this treatment to slow down these changes. And it works better the earlier in the process we give it. So I definitely recommend, if you have concerns about your own memory and thinking, or, a loved one's memory and thinking, definitely talk to your primary care doctor about it, see if you would benefit from an evaluation, or reach out to your local memory clinic and get an appointment. And sorry, I went over a little bit, but I will open it up for questions.
Thank you so much for that. There are lots of good questions in the chat. So I'll start there, and then if people want to ask after, we'll do that. But the first question was, are there experimental studies in process to better understand if more steps per day reduces the risk of dementia? Oh, I think you talked about that, but I don't know if you have more to say.
Yeah, so that's a great question. So, most of the studies that have shown that benefit are what we call observational studies. So that's where, we just recruit a bunch of people and they don't, we just recruit all comers in the community and we follow them over a period of time to see, if we can figure out different things that they're doing or different risk factors that they have that affect their risk of dementia. So it's been observational studies where we've seen, a benefit of the step count with dementia risk. And the reason we have to use observational studies is because it would be very hard to do a study where we, told one group of people to get 10,000 steps per day, another group to get, 2,000, and follow them for like 7 years. It would be very hard to do that study and to keep people on that regimen for that long. But there have been studies that have looked at exercise as a treatment for mild cognitive impairment. So these are people who have changes in memory and thinking, but they're still able to do all their day-to-day activities. And these have been randomized controlled trials. So where one group was, randomized to receive the exercise, another group was randomized to, just do their normal activities. And then they're followed over, a couple of years, typically. Typically the longest is, like 2 years. And those studies, some of those studies have shown a benefit to exercise for maintaining cognitive function in people who have memory and thinking changes. So I think if we look at the evidence from different sources, it provides a pretty compelling argument that exercise can make a difference for the brain and help build that cognitive resilience, also help address some of those other risk factors that may be contributing. Whether that 10,000 step number is really accurate and true, hard to say because we haven't done a randomized trial to prove that. But still, we know that, people who get higher number of steps not only have a lower risk of dementia, have a lower risk of heart disease, lower risk of stroke, and live longer with less disability. So a lot of other great reasons to target, that step count if you're able to.
Okay, another question, Tom, I see your hand. I'm just going to ask some of these questions in the chat and then we'll get there. Why do you think the New York Times crossword had a bigger impact than the online brain games? Was it difficulty level or delivery?
Yeah, so that's a great question. What we've seen with some of the brain games is that, your performance improves, but it improves on whatever specific task that brain game is having you do. And how relevant that task is to your day-to-day life, I think is really questionable for some of these brain games. However, if you're doing the crossword puzzle, I think you're, in a sense, practicing a skill that we all use on the day-to-day basis, and that's speaking, communicating, reading, and processing written information and verbal information. And so when you're trying to figure out that clue, I think it's, exercising parts of the brain that you're using more for your day-to-day activities than what some of these other brain games are training. Some of these games are very abstract, picking out shapes here and there, or trying to remember sequences of, shapes or numbers that go back a few times. I just think those are less transferable skills to day-to-day life than something like a crossword puzzle, which is helping you practice vocabulary, practice kind of verbal reasoning, connect different verbal concepts. And that's something we're doing every day when we're communicating and when we're processing information.
Thank you. Someone asked, what is the benefit or harm of B12 in terms of long-term risk for dementia?
Yeah, so that's a great question. So B12 is a vitamin that we need to obtain from the environment, and it's found in meat products and some plants, and it has a very complex absorption kind of system, just by virtue of some of the characteristics of the vitamin, and because of the complexity of the way our bodies absorb it, people tend to get less efficient at absorbing vitamin B12 as we get older. And so we tend to see those levels go down. And we know that vitamin B12 is important for nerve function, and people who have low levels of vitamin B12 can develop a neuropathy. It's something we check, and if it's low, we recommend supplementation. However, the evidence for that I think is pretty weak. And sometimes when we have people on supplementation, we see that their vitamin B12 levels are very high. There has been, I'm aware of one study that showed maybe a possible harm with excessively high vitamin B12 levels, but I think most studies have shown that it's not harmful. So, if patients have low normal vitamin B12 levels, I will recommend a supplement. But the evidence for that, I think, is pretty weak. And its role in contributing to dementia at a low normal level, I think, is also pretty unclear. And another thing to remember is that our livers typically have several years worth of storage of vitamin B12. So it can take a while for kind of problems to pop up, even if dietary intake is not high enough. So yeah, it's complex, and I think it's probably not a huge risk factor, but we routinely test people and we'll supplement if they're in the lower range of normal, and certainly if they're abnormally low. Yeah.
Someone asked about the supplement turmeric.
I'm sorry.
Someone asked about the
Right.
supplement turmeric. Yeah.
Yeah. So yeah, again, when you look, you can find studies that show a benefit, and then you can find studies that show no effect. Most of the studies are small, and a lot of them use different assessment tools, and so they can be difficult to compare. Again, I don't think it's harmful. I don't think there's any well-done studies that have shown conclusively that it helps. But I think if you're using it, especially as part of a heart-healthy Mediterranean style diet, then, I think that's a wonderful addition. I think with all of these different supplements, if you're eating, a heart-healthy Mediterranean diet that's rich in fruits and vegetables, that's very colorful, then you're getting a lot of these anthocyanins, so the chemical compounds that create the color in like berries and fruits. Those have shown evidence as being antioxidants that have beneficial effects on health. So some people take supplements with those in them, but if you're eating a heart-healthy Mediterranean style diet, then you're getting a lot of that already. So I think rather than taking specific supplements that we don't have strong evidence for, it's probably a better bet just to, try to shift your diet more to that Mediterranean style diet, make your diet more colorful. So, blueberries, blackberries, raspberries, lots of greens, lots of reds, lots of different colors. You're getting a lot of those anthocyanins, those antioxidants. And I think that's going to have a better bet, or a better, more likely to benefit your brain health than taking a specific supplement.
Thanks. Someone asked, what do they consider high blood pressure these days? It seems to have changed over time.
Yeah, so that's a great question. And there's still some controversy in the field. But what I look at is a trial called the SPRINT trial. So this was a trial that compared kind of relaxed blood pressure control to intensive blood pressure control, which was that top number less than 130, bottom number less than 80. So that's what I use. And that study was actually stopped early because there was such a beneficial effect in the people who received that intensive blood pressure control that it was unethical for them to continue that study. And there was also another study that was part of that where they looked at the risk of developing MCI and dementia. And they found that people who were receiving the intensive therapy with a goal blood pressure less than 130/80 had also a decreased risk of developing mild cognitive impairment and dementia as well. So.
We still have more in the chat, and I'll go back to that. But Tom, you've been having your hand raised for a little bit, so maybe we'll go there.
Yeah, I was just curious to ask you about some of the psychological risk factors. You talked about anxiety and depression, and I'm wondering if you can elaborate on the strength of those. And I was also thinking about the heart disease literature, where anger and hostility were pretty good predictors of heart disease. Are there other psychological risk factors like anger and hostility, or other ones we haven't talked about that you've seen in the literature that are promising?
Yeah, so that's a great question, and it can be complicated. So there is evidence that serious mental health diagnoses of things like schizophrenia, bipolar disorder are associated with an increased risk of dementia later in life. And it's probably strongest with schizophrenia, which some people would consider a neurodegenerative disorder itself. It's when we're talking about depression or anxiety, I think it's a little we have to kind of distinguish between what's happening over midlife and then what's happening later in life. So sometimes when older adults have depression or anxiety, that can actually be one of the prodromes of dementia or Alzheimer's disease, meaning that those depressive or anxiety symptoms are part of the Alzheimer's disease process, and sometimes they even pop up before people have changes in memory and thinking. And another one that we see commonly is what we call apathy. So people just become less motivated and interested in doing things. And some people will see that and they think, oh, this person's depressed, when sometimes that is just a manifestation of the Alzheimer's disease. I think looking earlier in life, there is a risk association. It's not one of the stronger ones, but definitely, and it also intersects with other risk factors, right? So if people are depressed, they're probably not exercising, eating a heart-healthy diet. They're probably, not as socially engaged as they otherwise would be. Sometimes people with depression have higher inflammation. So there, a lot of ways that depression and anxiety could intersect with dementia risk, and we're still trying to sort out some of those. With respect to personality factors, I've seen some papers looking at neuroticism. So neuroticism, I think, kind of broadly defined as just a tendency to experience negative emotional states. So people who have a more kind of neurotic temperament may be at an increased risk of developing dementia.
Thank you.
Okay, so some other questions from the chat are, how does the Duke Neurology Clinic on Marine Road work with the folks in the Duke Geriatrics Clinic? Would patients of the Duke Geriatrics Clinic need a separate appointment in the Duke Neurology Clinic for some of the testing?
Yeah, that's a great question. So we're actually trying to better kind of harmonize how we work together. And kind of our vision is that the memory clinic on Marine Road we're trying to focus our clinic on early diagnosis management, treatment with the new Alzheimer's drug lecanemab, and then plugging people into clinical trials. And then for people who already have a diagnosis of dementia, we're working with the geriatrics clinic to provide long-term longitudinal dementia care to those people. If you're already a patient at the GET clinic and you're interested in getting tested for Alzheimer's disease, I would recommend talking to your GET provider. Some of them are comfortable ordering that testing, and I'm happy to help them if they have questions about it, and they all know how to reach me. If they're not comfortable with that testing, then they can just refer you to our clinic and we can kind of do that. But some of them will order the testing to determine if someone's changes in memory and thinking are due to Alzheimer's disease. They will not be treating people with the new drug lecanemab. So if that's something that you're interested in, that would require an appointment with the Memory Disorders Clinic on Marine Road.
Okay, thanks. If someone would like to come to the Memory Disorders Clinic for an evaluation, is it an out-of-pocket expense? Additionally, what is the protocol once there?
Yeah, so typically it's covered by insurance. So whatever your standard copay is for a specialist visit would apply. So when you come to the clinic, we recommend that you bring a loved one or a trusted friend who can provide some context and what we call collateral for some of the symptoms that you're experiencing. So at that visit, we'll do a comprehensive assessment, look at risk factors for changes in memory and thinking, look at other things that might be contributing like sensory impairment, sleep disorders, other medical risk factors, medications that maybe contribute to memory and thinking, family history. We'll do cognitive testing. We'll do different assessments to look at mood, anxiety, as well as assessments to evaluate whether or not those changes are affecting day-to-day function. And then, we'll review imaging if available. If there's no imaging available, then we'll order that, which is most of the time an MRI. And then we also discuss diagnostic testing. So we have diagnostic testing for Alzheimer's disease and Lewy body disease, and then genetic testing for some other less common causes of dementia. And so for Alzheimer's disease testing, the gold standard that we use in clinic is going to be a lumbar puncture, which is a very quick, safe procedure where we obtain a very small amount of spinal fluid and check it for Alzheimer's disease proteins. And that's covered by insurance. Again, it's very safe and quick. It takes about 15 minutes. We numb up your skin with lidocaine so it doesn't hurt. And then we do have a blood test that we are piloting in clinic that also checks for Alzheimer's disease. The issue is the blood test isn't paid for by insurance and the out-of-pocket cost is $1,300. And also we can't, if someone is interested in new medication for Alzheimer's called lecanemab or Leqembi, then we have to use the gold standard test to see if they're eligible. We can't rely on the blood test. But we do have the blood test available if people are interested in that out of pocket. Yeah.
Okay. Someone asked, could reading and writing be as protective as working crosswords?
Yeah, I think definitely writing. I think because it's active. So if you are reading and then actively writing, whether summarizing what you read or you're writing essays or other things, I think that's a great way to exercise your brain. And my guess is if, they had the people do a writing exercise, that would probably, have been as effective or maybe even more effective than the crossword puzzle. So I think writing is a great way to work your brain. I think reading may be just a little too passive, although it's better than nothing and certainly better than watching TV. But I think something that's a little bit more active and engaged and a little bit more challenging. So maybe if you're reading something that's very complex that you're actually, spending time making sure that you understand and process, then that's probably good. But just kind of passively reading like, fiction novels or something like that, I think it's probably just a little too passive. So I would definitely pair it with the reading or the writing. Yeah.
How can we find out about Duke clinical trials and about participating?
Yeah, so if you Google the Duke UNC Alzheimer's Disease Research Center, and I'll just put it in the chat. There is a link on that website, and actually I'll just drop the website address that has all the trials that are being done. So like I said, we're doing a trial testing that medication lecanemab to see if it can prevent the development of changes in memory and thinking in people who have a strong family history. And so if you're interested in research, I would recommend looking at that website and you can find out more.
Someone asked if you had any thoughts about the MIND diet, which is more specific, they said, than the Mediterranean diet.
Yeah, so the MIND diet is a great diet. So the MIND diet is the Mediterranean diet and also parts of the DASH diet, which are a low salt diet for blood pressure. And also I think encourages, fruits and additional kind of colorful fruits like berries. And so I think, yeah, that's a great diet to the foundation is the Mediterranean diet, just has some other components, but yeah, the Mediterranean or MIND diet are both excellent choices. And, it's not like you have to do either 100%. If you can just kind of move your diet in that direction, that can make a real difference. So, you can still be on the Mediterranean or MIND diet and, have a milkshake every once in a while or a slice of pie, just, in moderation.
Someone asked, is the testing for Alzheimer's disease a blood test or an MRI?
Yeah, so that's a great question. We do obtain usually an MRI in all patients that we evaluate in clinic, but that's mainly to exclude other things that could be contributing to changes in memory and thinking, like mini strokes or increased pressure on the brain or tumors, things like that are less common. Sometimes on the MRI, we can see clues that the changes in memory and thinking might be due to Alzheimer's disease, but it's not definitive. So we can't diagnose changes in memory and thinking due to Alzheimer's disease just based on the MRI. And that's why we do the additional diagnostic testing. And so at our clinic, what we use is a lumbar puncture, which is about a 15-minute procedure where we collect a small amount of cerebrospinal fluid from the spine. It sounds a lot worse than it is. It's very quick. We numb up your skin with lidocaine, stick a very small needle in, get a little bit of fluid. It's over before you know it. Sometimes people have a headache afterwards, but usually there's no, symptoms from it. So that's what we use in our clinic. The other kind of gold standard test is what's called an amyloid PET scan. So this is where we give you a special radioactive tracer that sticks to the amyloid plaques in the brain, and then we take a picture of it, and that tells us how much amyloid is built up in the brain. So some places do that. That's typically much harder to get covered by insurance compared to the lumbar puncture, which is always covered by insurance. So that's the one we use. And as I mentioned before, we also have a blood test called the Procivity AD test that we are piloting in clinic. It's not a gold standard test. We can't use it to determine if people are eligible for that new medication. But it does perform reasonably well. It's just, it's not paid for by insurance, and the out-of-pocket cost is $1,300. So we haven't had many people who are interested in that. I do expect there will be a blood test that is widely available and is covered by insurance, probably in the next 2 or 3 years.
Okay, someone asks, do you consider Scrabble, Words with Friends, Wordle, and Wordle with crosswords or with online brain training games? Do you consider Scrabble?
So I love Scrabble because it's social, right? So you get that social interaction as well as you get something that's intellectually challenging. I think in the study by my colleague Murali Dorswamy, they compared the crosswords to the brain training games, and they found that the crosswords were more effective. So I think with the brain training games, they're kind of abstract, and I think you get better at the game, but whether that transfers to day-to-day life and to, kind of your general cognitive performance, there's not really much evidence for that. And as I mentioned before, I think the crossword, because it's, focused on language and kind of relating clues to words, exercises part of our brain that we use regularly, which is communication, speech, language. So I think that's my thought as to why that was more effective. So yeah, I think if it's something like Words with Friends, that has a social component to it, that's good. Or Scrabble, things like that, that are social are good. And then Wordle, I think Wordle's probably a little too short. If you compare it with something else, to get some more time, I think that would be helpful. In the study that my colleague did, they did 30 minutes of crossword. And so, I would try to aim for something that takes a little bit more time than just, the Wordle.
Someone asks, is there a test for tau tangles like there's a test for amyloid beta?
Yeah, so that's a great question as well. So we do also have a special radioactive tracer that binds to tau. So we can do a similar imaging type study to the amyloid with tau and look at tau burden in the brain. That's typically only done at research centers as part of studies. And then there are blood tests that are becoming available that are specific for tau as well. And so I expect that those will probably be part of the tests that become available in the next couple of years.
Now, the last question that has been coming up a little bit is that people are wondering if you are willing to share these slides.
Absolutely, yeah. I'll email them to the coordinators and they can share them.
Okay, cool, thank you. That's all for the chat. So I don't know if anybody else has any questions they want to either put in the chat or unmute themselves, raise their hand.
Well, thank you so much for having me. And if you do have any questions, feel free to shoot me an email. It's daniel.parker@duke.edu. I'll put it in the chat. I'm always happy to answer questions. And if you're worried about your own memory and thinking or a loved one's, definitely talk to your primary care doctor about it. Reach out to your local memory clinic and get checked out.
Thank you so much. That was a really great presentation. And as always, it's amazing how much there is to know and learn. And we appreciate you sharing your expertise and your time with us today. So thank you again for being here. And thank you all for being here to attend this program as well. So thank you very, very
My
much.
pleasure. Yeah.
Thank you.
Just to let you all know, I will wait for Dr. Parker's slides, and then I will be sending those out to you all. We do hope that you'll join us tomorrow. We're going to be having another talk, our last talk of the program. It's going to be with Jamie Rinker, who's going to be talking about protein's role in a diet for strength and longevity. So we hope that you'll come to that. I'll put in the chat a link for just more descriptions